Spy one, shall we start? Yes, I think the live is there now, so we should go ahead. So, shall we begin the class? Okay, thank you very much for yesterday's very good response and the student messages. Really happy for it, and I am very glad that you all understood and attended live session. So, let me tell you for those who didn't attend yesterday's live session or not seen the recording. So, yesterday we have covered the basic topics, be it antenatal care or be it hypertension and GDM, which are all equally important. Okay, so today we are going to cover on our day 2. Again, we have the same schedule of time, 5 to 7. We'll try and cover by 7 o'clock as much as we can. Okay, so today we are going to cover about the antepartum hemorrhage, postpartum hemorrhage, delivery and its complications also, and postnatal complications also. So let us quickly start over that what all we can cover. Let us see now. Okay, so to begin with, what is antepartum hemorrhage? Yes. Yesterday it was very nice interactive session. I want like that only today also. Okay, as we have already told you, the more you interact, the more you tell, the more you ask, the more you remember. Correct, isn't it? So that is why. So let us begin now from antepartum hemorrhage. So what is antepartum hemorrhage? Whenever there is a bleeding during pregnancy, okay, during pregnancy. So during pregnancy there is a period of viability, isn't it? So we have kept it as 28 weeks. So anything before 28 weeks we term it as miscarriage. So the 28, 24 is a debate, but for antepartum hemorrhage, it should be more than 28 weeks. So any bleeding during pregnant period before the viability is considered as a miscarriage. It is happening after the period of viability, that is considered as antepartum hemorrhage. So this much understanding you should know, because they will give you questions like, let us say a third gravida has come to you, she is right now a case of 28 weeks pregnancy and she is having bleeding. Last night she had bleeding in during the pregnancy. So this is her complaint. Okay, so you should decide whether it is a miscarriage or it is an antepartum hemorrhage or it is any other complications. In antepartum hemorrhage we have basic two things which I'm going to tell you now. So first thing is differentiate whether it is miscarriage or it is an antepartum hemorrhage. So if it is after the period of viability, then we say it as a antepartum hemorrhage. If it is before the period of viability, then it is a miscarriage. Okay, so this much you have understood. So coming to the antepartum hemorrhage per se. So we have a basic classification for this, that is the placental causes, which accommodates to the major part of antepartum hemorrhage, and this is a must know topic. Okay, so wherever you are there as a doctor, a pregnant lady comes to you at 30 weeks, 32 weeks with a bleeding, you should be able to differentiate, or you should be able to first of all recognize it as antepartum hemorrhage and tell her, yes, this is a antepartum hemorrhage, this is a complications very severe, and tell her whether it is placenta previa, abruptio placenta, and treat her accordingly. So whichever subject you are, these are the basic must knows for every doctor. So these questions are always there in exam for that reason. So remember, the topics which are common, which are important, are the topics which are always there in exam. So like yesterday I told you, the hypertension, isn't it? So in hypertension, always there is a question. Why? Because we cannot afford to miss a case of hypertension. It is very important, isn't it? So that is the reason. Now coming to antepartum hemorrhage. So whenever you are reading a topic, if there are multiple questions on that means it is a must know. You cannot have a choice of not knowing this topic. That is why there is always a question in this. So coming to the antepartum hemorrhage, the placental causes. There are two major causes in this. The first one being the placenta previa and the second one being the abruptio placenta. Okay, so the PPs and the AP. So first we are going to talk about placenta previa, then we'll talk about abruptio placenta, then we'll see what is how to differentiate in exam with the clinical features or the findings that they give you. Okay, other than this there can be other causes like vasa previa, which is a fetal bleeding. So here there is a fetal blood vessels that is running in the membranes, okay, which is lying over the os. So let us take, this is the placenta and this is the fetal blood vessel lying over the os. Okay, these blood vessels are running in the cervical os, in the membranes. So whenever we do PV or whenever there is accidental rupture of this membranes, the fetal blood vessels will get ruptured. In vasa previa, we have fetal blood loss. Okay, this much you should know about this fetal blood loss. Whereas in a normal antepartum hemorrhage, let us say placenta previa or abruptio placenta, it is maternal blood that is lost. losing. Whereas only case where we lose the fetal blood, it is because fetal blood vessels are ruptured, isn't it? So that is the reason here we have fetal blood loss. So whenever there is vasa previa, very high chance if they have a APH that we can save the baby. In the others, so at least we can save it the earliest they came, the early we treat everything. Here, since the fetus will lose its blood very fast and fetus hardly has any amount of blood volume also, isn't it? So that is the reason it will lose very fast and very difficult to save this fetus also. Okay. So other than that, you can have a suction rate load or abnormal placenta or local causes like cervical polyps or a carcinoma, varicose veins, traumas, and cervical ectopy. So these are the other causes. But most important is placenta previa, abruptio placenta, sometimes questions on vasa previa. This much you know. Now let us go ahead with the placenta previa. So what do you understand by placenta previa? So here in placenta previa, what happens is that if this is the normal uterus and here should be the normal. Normally, placenta is placed anterior, fundal, or posterior like that. Okay, but here what will happen? It will come down to the lower segment. When do we say it as lower segment or placenta previa? When it is within 2 centimeters. So here you can see. So here you can see it is within 2 centimeters of the margin of the os. So this 2 centimeters first you should remember, because they will give you placenta is lying 1 centimeters from the os. They'll give you sometimes placenta is lying 4 centimeters away from the os. Is it a case of placenta previa if they've given you a 4 centimeters away from the os? No. So if it is lying within 2 centimeters of the os, then we call it as low-lying placenta. Okay. So this is the os and this 2 centimeters gap is there. So within 2 centimeters, there is a placenta that is coming and sitting there. That means it is a case of low-lying placenta. And if it is completely covering the os like this, okay, then it is placenta previa. Let be it covering marginally or be it covering fully like this. Either it is covering marginally or fully like this. Both of them are placenta previa. Initially, when I was studying, I had these classification type 1, type 2, type 3 in that anterior, posterior, Stalworthy sign. I'm sure a long-standing student would always know this, or who studied your OBG in your first year or something like that. You always know what is Stalworthy sign. When we take the fetal head and push it into the pelvis, we'll have fetal bradycardia, isn't it? So that is called as Stalworthy sign. So here, when the placenta is low-lying, especially the posterior placenta previa. So let us take, this is the placenta previa posterior and the fetal head comes up. Okay. So here is the fetal head. So now you grasp the fetal head and you'll push it into the pelvis. So that time what will happen? This fetus will compress on the placenta. Correct? No. So this, when it is compressing on the placenta, so the blood flow to the fetus is not going, because there is constriction, there is compression of the placenta, blood flow is not happening. So what will happen? Fetal bradycardia will be there. Correct? No. So this bradycardia is called as Stalworthy sign. Okay, Stalworthy sign in most commonly seen in case of posterior placenta previa, especially if it is type 2 and below previously, but now right now you can say just complete placenta or low line. Whenever there is a, when you push the fetus and there is bradycardia, you can say it as a Stalworthy sign is positive. So she'll go directly for a elective cesarean section. Normally there will be no bradycardia. Only when you push the head on the placenta and there is compression on the placenta, that time only. Okay. So let me see if yes, Naman, you gave the correct answer. Stalworthy sign. Yes. Okay. Yes, cavalier uterus also. I'm going to show you the photos in recent soon. It is coming. Don't be in a hurry. Cool and calm. So that is the key for exam. Be cool, calm, revise. Cool, calm, and revise. Don't panic. Don't need to take any sort of tension. You have read well. You will answer well. Okay. So let us go ahead. Now coming to the complications. So this is about placenta previa. This is where the major questions lies. Okay. And I will tell you the clinical features in relation to the abruptio placenta so that it is easy to remember and recollect. Okay. So coming to the complication, majorly it is maternal complication. Compared to abruptio placenta, here the fetal loss is less because it is very profuse bleeding and patient comes to hospital very early. Okay. So that is the reason here the complication to the fetus or the chances of abnormal fetal heart rates or fetal loss is less Not that it is not there, it is less compared to that of abruptio placenta. That is all. Okay. So in this photo, you can see what is given. The placenta has come out first, and then the fetus and the umbilicus cord is coming out, isn't it? So it is a dead baby, I think. So since the placenta has already come out, then the fetal limbs and umbilical cord is coming out. So it becomes a complex presentation because there is cord and the foot, everything is that is coming out. Usually footling presentation, even if the placenta was normally situated, footling position is never a case for normal delivery. Footling position is always a case for cesarean section. I'll tell you in breach in coming more slides. Okay. So this is about placenta previa. So bleeding related complications. These are the most common complications, be it DIC, shock, renal failure, multi-organ system damage. All these things is common because of bleeding. Bleeding is the most common complication, and related to that, everything you can choose from smallest as anemia to a multi-organ dysfunction. Okay. Next, coming to abruptio placenta. So now you know placenta previa means the placenta is coming down and situating. So what is abruptio placenta? So if this is the normal placenta, okay, let us take this is the normal placenta. Okay, a normally situated placenta separates before the delivery of the baby. Okay, normally when should placenta separate? In stage 3 of labor, isn't it? So by that time the delivery is almost over. The fetus is all out. After that is the delivery of the placenta. That is when it should separate ideally at stage 3 of labor. Correct? No, so stage 3 it should separate. So it is happening before stage 2, before the delivery of the baby, if there is the separation. Okay, that is called as premature separation of a normally situated placenta. Okay, that is called as a abruptio placenta. Why I'm stressing all these things is because many a times they will give you an explanation and ask you the definition also or the diagnosis also. Okay, so here it is before only separating. Now coming to the types of abruptio placenta. So remember, antepartum hemorrhage, as I have told you, it is all after 28 weeks, after period of viability. Before period of viability, it is miscarriage, both for placenta previa and for abruptio placenta. Okay, so coming to the varieties of abruptio placenta, there are three things. One is concealed, one is mixed, and one is revealed. Okay, so what is concealed? So that means there is hemorrhage, like in the first photo there is hemorrhage here, but you are not able to see the hemorrhage. Okay, patient is having clinical features, I'll tell you. They are like severe pain, abdomen, continuous uterine contraction, fetal distress is there. So you're finding all the positive signs of abruption, but there is no bleeding at all. Okay, so that makes it a concealed kind of a hemorrhage where we are not seeing it, but there is something happening inside the uterus. Correct? No, so that is concealed. Next comes the mixed one, which is the most common one. So it gets separated. From the separated part, some amount is coming out, some amount is still inside itself. So concealed and revealed both are there. That makes it mixed. Okay, mixed is the most common presentation of abruptio placenta. Okay, then comes your revealed type. So everything that is come out is come out. All the hemorrhage is come out, no problem. But nothing is there inside right now. So what will happen? Patient tells, I had a severe amount of pain and there was bleeding also, doctor. But you do scan, there is no retroplacental clot. All the placenta is fine. Everything is fine. So that time it would have happened like this. This marginal separation would have happened and that clot would have come out. It is completely revealed right now. So that is the reason there is no placental separation that you can see right now. Okay, usually it is very rare, but still it can happen. Okay, so this becomes a reveal. What you see is revealed. What is inside which you cannot see is concealed. When both are there, then it becomes a case of mixed type. Okay, so these are also important questions. So they can give you abruptio placenta, it is concealed, mixed, or give a history scenario, give a placental finding or a scan finding, and then tell what is whether it is concealed, mixed, or revealed type of hemorrhage. Okay, coming to the classification of placental abruption, so it has different grades, grade 1, 0, 1, 2, 3. So in 0, what will happen is that, yes, here there is no problem with the baby or the mother. You delivered everything fine, But later you saw that there was a retroplacental clot. Maybe it was small, which was not affecting either mother or the baby. Okay, so this becomes grade 0. Okay, so here you have clinical features may be absent. Mother was fine, baby was fine, you did a normal delivery, everything was fine. But suddenly after the delivery of placenta, you can see a huge bout of clot coming out, or behind the placenta there is a clot sitting on the placenta. Diagnosis is made after inspection of the placenta following delivery. Okay, so you just made a retrospective diagnosis. Everything was fine. In the last, after the placenta is out, oh God, there is a clot here. She had an abruption. It was grade 0. Okay, that makes it grade 0. Then comes a grade 1, which is 40% incidence. So here what will happen? Here the vaginal bleeding is slight. Okay, there is not much of vaginal bleeding, and there is there a gap between my speed and the marking? Somebody please tell me. If all okay, then can we continue? If I'm very fast also, you can slow me down. You can message, ma'am, slow down. I will slow down. Since it's a quick revision, I want it to happen fast and don't want we want to waste your time, because you have 19 subjects to study. I have one subject to teach. Okay, no, there is no problem. So we'll go ahead. Yes. So next, coming to the uterus. Here the uterus would be irritable, tender, and minimal it is, or it might be absent also. Okay, so the all the features are in minimal side. There is minimal amount of bleeding, minimal uterine tenderness, minimal irritability is there, maternal BP, blood investigation, fibrinogen, clotting factors, everything is normal. But there is abruption. You also know before delivery, patient also know there is antepartum hemorrhage. Okay, and most important is FHS. FHS is good. There is no problem with the baby. In 1 and 2, I mean, sorry, 0 and 1, there is no problem with the baby. Okay, so this makes it a grade 1. Next, coming to the grade 2. Here, what will happen? Here it is increase in degree now. Okay, vaginal bleeding mild to moderate, uterine tenderness becomes very prominent. Always it is present. Okay, so in the grade 1, it might be there, or irritable or mild tenderness. So here the patient is having so much tender uterus. It is very painful for her. Okay, then her maternal pulse and BP, okay, are well deteriorated. So that means you can feel the tachycardia, you can record the BP is falling down. So all those things would have started happening. The compromise is already started. Okay, so here tachycardia, hypotension, everything is there. Then fibrinogen level may be decreased here. Shock is not there. Okay, this is one important feature. Shock is not there. Okay, so shock is absent, which is there in case of grade 3. Okay, almost here the bleeding is little more. Here, as we told, mild to moderate. Here it becomes severe or maybe concealed. You're not able to see, but the patient is deteriorating rapidly. And then uterine tenderness is marked in both of them. Whereas in grade 2, there is no shock. Whereas in grade 3, there is definitely a shock patient. That means hypertension, she is on adrenaline or vasopressin. Already the compromise is started. And in 3, always there is a fetal death, whereas in 2, fetal distress is there. Sometimes can have fetal death also. Okay, fetal distress or even fetal death occurs. So if they have given you a history saying she had mild bleeding and then okay, I will give you a history example now. I want the answers on the comment section, quick and fast. Okay, no more wasting time. So here is a patient. She is second gravida, comes to you with complaints of bleeding PV. You saw her uterus was tender and painful, and also you recorded her. There was, when you did a speculum examination, there was very minimum amount of bleeding, and on scan you sent, there was a small 1 centimeter retroplacental clot, and fetal heart rate was not found. What is the grade or the classification of abruption? What is your diagnosis? Grade 0 abruption, 1 abruption, 2 abruption, 3 abruption. Yes. Mm-hmm. You want me to write it down? A second gravida comes to you with antepartum hemorrhage at 30 weeks. She has mild bleeding on examination. Yes, I already got one answer. Very good, correct. Two answer, very good, correct. Mild bleeding is there. And also, there is tenderness, which is mild. There is no tenderness much, mild tenderness. And you did a scan which said just 1 cross 1 centimeter clot is there, abruption and retroplacental clot. And the FHS is absent. Yes. Okay, there are two people who told as correct answer, but the others are giving me Shruti is given again. No Shruti. See, two people who gave me correct answer. One is LBTT something, and one is Dr. Taran. Okay, I am not getting your name because of your email IDs. But anyways, so you two have given the correct answer. That is grade 2. Okay, here we, though it is all mild, mild pain, mild bleeding, mild tenderness, since the fetal heart rate is not there, there might be enough amount of bleeding that has caused the fetal distress and death, isn't it? So she might be in early stage or later stage of grade 2. Okay, so this becomes grade 2. So everything is mild, there is no much deterioration to the patient. Since the FHS is not there, she becomes to grade 2. So this is how you will classify. Had I given FHS plus, then she would have become grade 3, sorry, grade 1. But had I given as deranged fibrinogen, patient is in shock. I told you she came to you with APH. She's not in shock. She's walking and talking patient, isn't it? So that means she's not in shock. So that is why she's not grade 3. Had I told you she's in ICU, there is severe tachycardia, BP is only 60 by 40, like that, severe hypotension history, all these things had I given you, then she would have become a grade 3. Since everything is mild, but only FHS was not there, so we will categorize as grade 2. If I had given FHS plus, grade 1. If I had given diagnosed it after delivery, then she'll be grade 0. I hope you understood. Shruti, you understood? Yes, and Nishchit Patel. Okay, you also understood? So you both gave a wrong answer. Rest they gave a correct answer. Okay, the basic understanding here is the degree is not based on just one category. You have to take everything how the patient presents with to classify her as which grade. Okay, so that is why knowing the grades are important. Do you want to take a screenshot of this? Shall I clear this? Do anybody wants to take a screenshot of this? I'll clear the screen for you so that you can take a screenshot and we can do and you can read it or paste it somewhere so that you can easily recollect. We're expecting such sort of questions this time because yes, there is very high likely clinical scenario based and also these questions. That is why. Okay. So study well and such things are very important. So coming to the clinical features of abruptio placenta. So in one of my reels or one of my promotion videos for the live session, I told you the weather is distracting you all. So don't get distracted. In Bangalore right now, it is raining cats and dogs near my house. Okay. So it might not be the same in every place of Bangalore. But yes, right now near my house, it is raining like this. I hope would not be any Wi-Fi problem and there is no signal problem and we continue with the class. Okay. So it is raining so much. It is such a beautiful weather, but still our aim and focus should be on our class and study well so that our exam goes perfectly fine. Okay. So now coming to the clinical features of the placenta. So here it depends upon the degree of separation. As we have told, what is the grade 0, 1, 2, 3? It depends upon the degree of separation and what kind of separation, whether it is a concealed, revealed or mixed variety. So based on this, we will classify. So before going into the clinical features or the distinguishing features, I will just show you this photo. Yes. What is this photo? Yes, somebody had messaged me in the initial of the class. Wanted to see this. So what is this? Okay. What is the image shown in the slide? Mm. Yes. Yes, again, I got the correct answer from the same person, LBDT5GS. So the image shown is the covular uterus. So here, what happens in abruptio placenta? Let us take it is like this. The placenta is here, it has got separated, and this is the clot. Okay, this is the clot that was there. So it was a concealed kind of variety. Let us keep it as. So in concealed kind of variety, what will happen? It is just collecting behind the placenta. There is nowhere that it is going right now, isn't it? So what happens here is this hemorrhage, instead of coming out to the through the vagina or through the os, so it will start seeping into the myometrium. Okay, so this is called as covular uterus. So you can see after delivery, such kind of image, you can see that means it is a case of a covular uterus. There was abruption which was very severe. It started seeping into that of the uterus. So that is why a case of abruption, we always try and deliver faster. Okay, why we want to deliver faster? Because abruption compared to placenta previa, fetal loss is little higher side, and also the complications following delivery. Also the for every case of APH, there is always PPH. Be it placenta previa or abruptio placenta, if they had APH, they'll invariably some or the other type of PPH they'll have. Okay, so that is why to prevent that, we want them to deliver faster in abruption. So this will seep into the myometrium. They can give you a covular uterus, they can ask you the mechanism or some anything question on this. Okay, what is this also? As simple as that. So this blood starts seeping into the myometrium. So this is how it looks. What is the problem? Let it seep into the myometrium. Anyways, baby is getting the blood supply. What is your problem? What will happen if it doesn't, if there is a covular uterus? It is just a name that you want to know? Mm-hmm. I hope the screen is come back now, Dr. Taran. Is there still a problem with the screen? DIC. Mm. See, for every bleeding, finally it will end up, if you're not controlling, it will end up in DIC. As I told you, so that's why I didn't describe too many complications of placenta previa abruption. The thing is, if ever the bleeding continues, she goes into shock, there is consumptive coagulopathy, all the platelets are used up. So that is called as consumptive coagulopathy. What kind of DIC is seen in hemorrhage or PPH or APH in pregnancy? DIC is seen. What kind of DIC? It is consumptive. So that means all the platelets are used up. So they can give you different options. It is consumptive coagulopathy. So all the platelets are used up. That is why it can cause DIC. So for every PPH, APH, it can be there. But particularly for coiler uterus, I am asking there. Mm-hmm. Yes, PPH will be there. What is the basic reason I wanted to know? Yes, there is very high chance of PPH following the covular uterus. They said Nitish has told it is PPH. You are 100% correct. Why is that? Because this, what is the basic mechanism to prevent PPH? The living ligature of the myometrial walls, isn't it? So the myometrium walls should contract so that there is the sinus vessels will get blocked. If this is a vessel, so myometrium will get contracted and this vessel will get blocked. There is no more blood loss. So since there is seeping of blood into the myometrium, these myometrial contraction would not be efficient. Okay, so this living ligature would not happen appropriately. That time what will happen? The contractions are not efficient, the sinuses don't close up, then there is more PPH. Okay, many times a covular uterus would require a surgical methods of suturing. That is your B-Lynch suture or modified B-Lynch, Heyman sutures. All these things they may require because the myometrium is not very good contracted. contracting. Okay, so they're not having the strength because of the dispersion of the blood into the myometrium. They're not having the strength to contract, and also they would not be effective contraction because of the blood in the myometrium. So this is the basic reason for having BPH. Okay. So coming to the distinguishing features. Now you will tell me, I will tell the feature, you will tell me what is it in placenta previa and what is it in abruptio placenta. Okay, let us start. So in clinical features, what is the nature of bleeding in case of placenta previa? That means what type of bleeding? It is painful or painless in placenta previa. Mhm. Yes, first you should answer nature of bleeding. Is it painful or painless? First you'll tell me placenta previa, then you'll tell me for abruptio placenta. I think this delay is normal in case of live sessions because every time I'm seeing I'm slower in the session than I'm here. Okay, it's almost coming 1 minute later. Yes, very good. They just give me the first correct answer. So many people give me the very good correct answer. Nature of bleeding, it is painless in case of placenta previa and painful in case of abruptio placenta. This basic differentiation, if you know, it is more than sufficient. Why? Because most of your cases, or when they give you a scenario, it starts with this. Comes with complaints of painful vaginal bleeding, antepartum hemorrhage, or painless vaginal bleeding. So most of the time, this gives you a clear-cut idea whether it is placenta previa or abruptio placenta. So this is very important to know. Okay, this is 100% you should know. What by some unluckiness in our history, they did not describe it specifically. So they have given you the color. So what is the color in placenta previa? Yes. I think first time LBDT 5GS has given a wrong answer from the start of the class. Till now, we gave all correct answers, I think. Dark red, brownish. No. The basic difference between these two is placenta previa, it is a fresh bleeding, isn't it? It separates and it comes out. So it is a fresh bleeding. Patient will get up in a pool of blood. It is not a collected blood which was retroplacentally collected and it is slowly sleeping down to be dark red or brownish. Correct? No. So how can it be dark red? Why did everybody answer? Everybody has understood it in a wrong way. Okay, everybody is given it as a dark red. Okay, it is bright red. Okay, dark color blood is seen when there is a old blood which is coming out. Like in retroplacentally, there was a clot. Okay, slowly it started sleeping out, seeping out. In that process, the blood would have got clotted and it will become dark in color. So that dark red is seen in abruptio placenta, not in case of dark red or brownish is seen in case of abruptio placenta. Whereas in case of placenta previa, it's bright red. It's a fresh blood that you can see. Okay. Or when they describe you as fresh blood or bright red blood, that means you should think, yes, this is a case of placental previa, not a case of abruptio. If they give you a dark red, brownish color, then you should think in terms of abruptio placenta. Okay. Next, coming to the blood loss. Mr. Worldwide, I didn't get your answer initially. Okay, you have given a correct answer. Maybe I missed in the comment section, but I have not seen any answer from your end. Okay, so maybe it didn't get time to prescribe. No problem. Now you answer me. What is the blood loss? What do you understand? What is the blood loss in placenta previa and what is the blood loss in abruptio placenta? Mm. Mm. Mhm. Okay, I think you're not understanding the question. But anyways, blood loss means the amount of blood loss. What we see and what is the blood loss that has actually happened. This is what I'm trying to ask. In placenta previa, is it more? Or in case of abruptio placenta, it is more. It is not 500 ml, 600 ml blood loss. Any blood loss is always APH. Even it is as low as 50 ml, as low as one pad she has changed, still it is APH. Okay, we're not quantifying it like that. We are quantifying it how? Okay, the amount of blood we saw, is it the same amount of blood that she lost? That is how we are trying to differentiate. Okay, Shruti says less compared to abruptio placenta. Hmm. See, the basic thing that I'm trying to tell you is, in case of placenta previa, whatever is the blood loss, the same amount of blood loss we will see here also. Let us say she lost one full underpad of blood was there. The same amount we are seeing also. There is nothing hidden in this case. Okay. So everything is same. So what we see is what we lost, or what the patient has lost is what we see. This is the amount of blood loss. Let us say one underpad she has lost. There is nothing hidden or nothing that we did not see. Let us say in the house only she had antepartum hemorrhage. She will tell you my full dress was soaked, or she'll get you the dress, or she'll get you the this one. This much amount of blood loss was there. Many times patient have done this. Okay, so this is in placenta previa. So what we see is what the actual loss is there. Whereas in abruptio placenta, it is not like that. We might see very minimal bleeding. You can tell, हाँ स्वल्प bleeding or minimal bleeding is there. थोड़ा थोड़ा जा रहा है, कोई problem नहीं है. No, it is not like that. Maybe the bigger part or the huger amount of blood loss is inside, which we are not seeing. Maybe it is in case like a covulate uterus is happening. There is retroplacental. It is a concealed type, or very minimal mixed type is there. Very minimal revealed and maximum is concealed. Is it? Cannot be done based on the visual blood loss. Okay, it depends on the clinical condition, whether she has tachycardia, hypertension, what is her hemoglobin drop, what is her fibrinogen level. So it depends on the complete investigation profile whether she is had severe loss or no. But whereas in placenta previa, we see okay, this much amount she has lost, so this much amount of replacement will be required. So it is not the same in case of abruptio placenta. This is what I was trying to tell you. Okay, and more in placenta previa, less in placenta previa, it is nothing like that. Okay, whenever placenta previa also, there are many times warning hemorrhages. You'd have heard this. For example, usually placenta previa is diagnosed after how many weeks? Yes, it is after 28 weeks. So in placenta previa, what will happen? There is something called as warning hemorrhage, where at 30 weeks, 32 weeks, patient has minimal bleeding like that. Okay, so not that only abruption or placenta previa, huge amount of blood loss is there. We are seeing the huge amount. There it might be clotted. Clotted blood is even more blood loss than the fresh blood. Okay, so it depends on when in warning hemorrhage, the hemorrhage might be very minimal only. Okay, but what we see is what the loss is there. This much you should understand. Okay, compared to controlling part of the hemorrhage in placenta previa, it is difficult to control for us. Many times placenta previa patients end up in case of a cesarean hysterectomy or postpartum hysterectomy compared to a abruptio placenta. For us to control, it becomes difficult in placenta previa, but by nature placenta previa doesn't have much of problem. Like features of preeclampsia, who will have features of preeclampsia? Okay, now this is very easy. Mm-hmm. Yes, Dr. Taran gave the correct answer, has understood the concept. There is hidden blood loss in abruptio placenta. Correct. So that is why we cannot, what we see is not what the loss is. Okay. So these things, in any tricky way they give you a question, I'm sure you should be able to answer these questions. Okay. So whatever they twist and turn, if your concept is correct, you don't have to mug it up also. There also, you just wait, close your eyes for 30 seconds and recall it. What will happen? Why this? Why painless? Why painful? You will easily answer every question. Okay. Why Nitish Nitish Patel, what is your answer for the preeclampsia? Features of preeclampsia seen where? Mm-hmm. Dr. Taran, give me the answer. Yes, Dr. Digvijay Singh gave me the correct first answer. So in abruptio placenta we have preeclampsia, not in case of placenta previa. Placenta previa is a structural kind of anomaly, isn't it? So here it is a structural. Instead of getting attached to the upper part of the uterus, here it is coming and attaching into the lower part of uterus. There is no much relation with the or because of preeclampsia placenta didn't come down, isn't it? So it has come down by itself. Here there is no much association with preeclampsia. But why there is premature separation? Why should the placenta separate even before the baby is delivered? That happens in a case of severe uncontrolled hypertension. So that is why whenever it is 160 by 110, we want to control the BP immediately, because if you don't control, she will either end up in seizures or end up in abruption. To control BP, these are the body mechanism that it will do. Okay, it will try to push the baby out. First thing is placenta go. So that is why abruption is very common in case of uncontrolled hypertension, especially the severe hypertension, the preeclampsia, one of the dreadful complication. Neither it will end up in eclampsia if it is uncontrolled, or it will end up in abruption placenta. So prevent that only we give MgSO4 also in whenever the BP is more than 160 by 110. Okay, so abruptio. Placenta previa is a structural kind of anomaly. Where do we find these? What are the risk factors? Like, for example, infertility treatment or IVF conception is there, or uterine septum is there, anomalous uterus is there, or multiple uterine manipulations have happened, or previous cesarean or DNC, the excessive curettage is done. So it is structural kind of a abnormality which will lead to the placenta previa, not a systemic disease which will lead to the placenta previa. So whereas abruption, why did it separate before? Because of high BP. Unless until we see any other particular reason for abruption, most common association, if there is abruption, almost like 99% I have seen it is associated with preeclampsia. Okay, so keep it as 90%. The other common reasons are sudden decompression. For example, it was a twin pregnancy, first baby delivered and the uterus suddenly become less in size, like a balloon which was initially very big suddenly became less in size. Since the placenta is not elastic, it will start separating off. So sudden decompression, when you do ARM, you rupture the membranes and you let the liquor flow suddenly. You should always do controlled ARM also. That is your as rupture of membranes. Okay, artificial rupture of membranes. When you rupture it, you should do slowly and control. If you do sudden and remove your hand, suddenly the fluid will gush out, so that time separation of placenta would happen. So these two are most common reasons for abruption. One is preeclampsia, polyhydramnios with sudden ARM. Okay, so any history they can give you. So whenever you do rupture suddenly, so that time there is a sudden gush of fluid and the placenta separates off. Okay, so that is why you should never do like that. So these two are the commonest association for your placental abruption. Okay, next, coming to the next some of clinical features on examination. Okay, I hope Shruti, Dr. Taran, LB, DTS, 5GS, everybody understood why preeclampsia is more associated with abruption and not with placenta previa. Okay. back. Sorry for the delay. Yes, now coming to the parameters of clinical examination findings. Okay, so examination findings, what is the height of the uterus? In case of placenta previa, is it changed, or in case of abruptio placenta, where do we see the change? Okay, Nitish has asked for a video-based series to come on APH. Okay, yes, we'll try for you if you want that. We can try definitely. Yes, see, video-based or audio-based or image-based, whatever it is. So you can see whatever I've given you images, or be it a covalent uterus, be it everything. It is the similar concept that they are going to tell. Just because they give you another 2 seconds of video or 5 seconds of video doesn't going to change your diagnosis, isn't it? So maybe they'll give you a clinical scenario. Most commonly, I'm expecting an image-based, and video based may be there, but it is going to be the same image. They are going to focus it. Let us take like yesterday's class, NT. I directly showed you the NT image. They may focus here, there, and then come to the NT for you and go back. So it is the same. If you know the NT, you'll catch it up there also. Similarly, in placenta previa and abruptio placenta, the MRI findings, I'm sure the radiologist has taught you. So that is why I'm not included, since we have only 2 hours of class. If you want, I'll do that. No problem. We can do a video based session also. Okay, Nix has given the height change is seen in abruption placenta. He's the first person to answer. Yes, you are absolutely correct. So, height, uterine height might increase compared to the period of gestation in case of abruptio placenta, because of why? Concealed kind of hemorrhage. So, something is inside. Now, you have got the hang of abruption and placenta previa, I'm sure. So, everybody is given a correct answer now. So, the height is increased. Yes, proportionate height of age of gestation in placenta previa. Yes, Dr. Tar has given such a long answer. Yes, very good. I appreciate your patience and your way of answering. Everybody has different way. So in abruptio placenta, the uterine height is increased, may be increased, not every case, but it can be increased. Where it is increased, in case of concealed kind of hemorrhage, the uterine height is usually increased, or in kind of mixed also. Okay, and what is the feel of the uterus in placenta previa and abruption? Yes, everybody has got the concept right now understood. So everybody has given clinical features. Understanding is, all of you have given a correct answer. I'm very happy for that. But symptoms also, I want you to learn it very well. Okay. Because they can give you clinical features, they can give you symptoms, they can give you image diagnosis, they can give you a photo. Everything you should be thorough. Okay. Feel of the uterus. Yes, come on. Boggy hard. Boggy means soft and palatable. Okay. Whereas hard is different. So both you have written. What should I take? Boggy is soft, not consistent. Yes, Digvijay Singh is given rigid tender. Yes, in abruption it is hard. As we have told, it is a tender uterus, isn't it? The uterus is continuously contracted. So you should write the term as contracted. Okay, usually it is contracted continuously. Whereas if it was a normal labor, how do you differentiate whether it is a small show along with a labor pains? Labor pains usually is having intermittent relaxation. Okay, intermittent relaxation will be there. So this word you can pick it up from your exam. If there is intermittent relaxation, then it is not abruption. Okay, it might be normal labor pains with a show, minimal show may be there, which is confused as bleeding. Okay, so in case of abruptio placenta, what will happen? It will be continuously contracted hard uterus. Okay, so hard and continuously contracted, then you think in terms of abruptio placenta. Whereas the feel of uterus in placenta previa is normal. Okay, height also is normal, feel is also normal. There is no pain, there is no tenderness. It is appropriate for the period of gestation. Coming to the presentation. Presentation means the lie of the baby, or the cephalic presentation, longitudinal lie, breech presentation, transverse lie, all these things. Which of these two will have more chance of malpresentations and malpositions is the question. Yes. Start answering. Everybody has given a correct answer. Very good for the question of feel of the uterus. Yes. Now coming to the presentation. Mm-hmm. Dr. Taran gave the first correct answer. Yes. So, since the placenta is in the lower segment now, the head would not come to the lower segment easily. So, it is usually transverse, oblique, breech. Malpresentations and malpositions are more common in case of placenta previa, whereas it is normally situated placenta. Everything in the ANC was all normal unless until she had this abruption, isn't it? So, that is why there is no change in malposition or malpresentation in case of abruption, whereas it is very common of malpresentation. I also showed you a photo, no, initially where placenta came out, foot also came out, umbilical cord also came out. Malpositions and malpresentations are very common in case of a placenta previa. Coming to the FHS, this I've told you in the class itself multiple times. Which one has more chance of deterioration of the fetus? Abruptio, the fetal deterioration is very fast compared to that of placenta previa. Both of them there is deterioration in the fetus. In abruption, it is comparatively very fast and very high chance of stillbirth and intrauterine death compared to here. Here also it is there, but here it is very severe. That's all. In placentography or an ultrasound or MRI, you can see placenta is situated in the lower segment in case of placenta previa, whereas in abruption, it is upper segment with retroplacental clot that you can see. Okay, this is the basic understanding you should have. Okay, so now you answer me this question. Yes, Digvijay Singh again gave me the correct answer. Distress FHS is more common in case of abruption. Yes. A 32-year-old woman at 35 weeks of pregnancy with painless vaginal bleeding and no uterine tenderness, fetal heart sounds are normal on Doppler. What is your probable diagnosis? As simple question is this. Okay, this is not for you. I think this is just for second year MBBS, isn't it? You're so thorough and tip of your toes and tongues you are. Mm-hmm. Yes, everybody is correct. Placenta previa. This is very simple question. Now comes the difficult part of it. I want you to write the correct answer for all these things. Okay. One matches to what? A, B, C, D like that. Two matches to what? And three matches to what? Four matches to what? Five matches to what? Two and four, five, I'm sure you will answer because you just read. So this is just to recall your all memory because exam doesn't focus on one particular subject, one particular topic, isn't it? So just to recollect all your memory right now. Yes, you will tell me one matches to what, one for what, two for what, three for what, four for what, five for what. First. Yes. Let me see who gives the first answer now. Yes, one for pituitary necrosis and postpartum shock. Very good. Nitish Patel gave me the first answer. Sorry. Tejas TS gave me the first answer. I'm sorry, Tejas. Mm-hmm. Okay, somebody innocent doctor has gone to five already. Five is E. Okay, this also you're correct. Mm-hmm. Shruti has told two is C, one is B. Let me see. Two is C. Painless vaginal bleeding. This is again correct. Two is C. And she has told one is B. That is already marked. Has also already marked. Somebody told for three. Mm-hmm. Three is D. Expectant management. Unless the stable mother less than 37 weeks, then we'll wait for the expectant management. So, based on the fetal maturity, maternal condition, you will decide whether when you want to deliver the patient. Concealed kind of hemorrhage, you will see retroplacental clot formation. 4 is A. Yes, everybody is correct. Very good. So I hope this brushed your knowledge and you'll be able to answer in your exam like this only and get good marks. So everybody gave the correct answer. I don't know, whatever for my knowledge I've seen, everybody gave the correct answer. Okay, now your next question. Mm-hmm. So many questions came up. From next time, I will stop asking questions. It is delaying the topic, I think. Or you want me to keep the questions like this only? Keep it more interactive? Can you see right now, students? Yes. Can you see the image? So shall I read the questions? Yes, already I got the answer. Phoenix has given me the correct answer. I'm sure you can see the question. That means yes. So here is a woman with history of previous one lower segment cesarean section, and that is LSES due to breech delivery. She presents to the ER with antepartum hemorrhage. Emergency LSES is performed but complicated with massive hemorrhage. As I told you, it is very difficult to control in case of placenta previa. In this case of image that they have given, it is placenta accreta, correct? No, so it is completely adherent to the uterus, so you can remember as so you so you can remember placenta accreta like this, placenta accreta. Can you see what I'm writing? Okay, placenta accreta. Okay, accreta, A for adherent. You can remember as like this. My goodness. And I for increta is invade. Okay, so grade 1, 2, and 3 you can remember like that. first it will get adherent, then it will perforate into the myometrium, then it will invade into the adjacent organs. Okay, this is how you can remember it easily in your exam. Are we good to go? Please somebody message. Are we good to go? Can you see the next topic? Yes, so Phoenix is saying we are good to go, and you can see the PPH slide also. Yes, so now that you can see PPH slide, you know what is PPH, everybody, I'm very sure of that, postpartum hemorrhage. So more than 500 ml has become more than 300 ml now. So with the clinical features, if there is any abnormal clinical features like tachycardia, hypotension, patient is feeling weak, tired, and clinical features, giddiness or generalized weakness, tenderness, everything is there. So it is 300 ml. Okay, so this is what you should remember, more than or equal to 300 ml now. Okay, now coming to the four more common reasons for PPH. One is the tone of the uterus, the most common reason for PPH, the tone of the uterus. Uterine muscles are not enough contracting, they have become weak, maybe whatever is the reason. So many n number of reasons are there, from APH to so many other reasons are there. Okay, so why the uterine tone? Maybe it is a prolonged labor, obstructed labor, or where uterine atonicity is there, or because of some abnormal uterine shapes, septums, all these things, the tone might not be acting well. Okay, then comes your tissue. T for tissue is the retained products. If there is any retained products are there, then is your trauma, and then is your thrombin. I'll show you the with the treatment option also. So if they have given you something like the uterus is relaxed, okay, that time your first aim should be to add uterotonics and to massage the uterus. There is PPH, and you can see the uterine tone is weak, or the uterus is not well contracted in your history, then your choice of treatment will start with uterotonics, medical management along with massage if there is already PPH. Okay, now coming to the tissue, if there is a retained tissue, okay, usually retained tissue, what kind of PPH they have? Secondary PPH. Okay, they present later date. Okay, maybe on day 7 or day 8 usually they present. So that is when, if somebody has come, you will do a scan, and if the scan says if there is some amount of tissue left over, you should do the curettage and remove the placenta. Or it can be like retained placenta. For example, now you can see placenta is not getting separated at all, or placenta is separated, or hourglass contraction, the cervix is got contracted. Okay, hourglass contraction, like that it will happen. So in such cases, the retained placenta will cause the PPH. Okay, or even in case of your placenta accreta syndrome is also a type of retained placenta if it is not coming out fully. Or one more reason may be a succinsurate lobe, abnormal placenta. A lobe is there, you have removed the placenta, you thought everything is come out, there is a succinsurate lobe which is still left inside, so removing that also is equally important after delivery. Now coming to the trauma and the repair. For example, they have given you a history which says she's having PPH, blood loss of 500 ml, she's continuously pouring, and she's clinically deteriorating, tachycardia is there, so many enormous history they have given you, and they've given you one line: uterus is well contracted, or the uterine tone is well maintained, uterus is hard to palpate. So any of these line is there, so that means uterine tone is good, the tone is not the problem. Now you should explore, maybe she's having a cervical tear, maybe she's having a broad ligament tear, maybe she's having a uterine incision tear, maybe she's having a vulval tear, maybe there is some vaginal tear, that is the reason why she's having bleeding. So trauma may be the reason. Okay, so these tears should be explored. First, look for the uterine tone, then look for the tears, then look for the retained placenta. Everything is normal, then check for the blood. Maybe it is consumptive coagulopathy, maybe it is DIC, maybe she's already lost before she comes to us itself. Okay, so that becomes the thrombin. Correct the coagulopathy at that time. Okay, now coming to the medical management, since this is a basic theoretical topic. I'm sure you've all read this. So uterotonics that we can use are oxytocin, methergin, carboprost, and misoprostol. Most important thing that you have to know in this case is that you should avoid what medication in what patient. For example, they have given you history saying she's having hypertension and all. She delivered vaginally and now her BP is 160 100. She's having PPH. What medicine will you give? Will you give her methergin? What medicine is contraindicated? This is the most common question. Which medicine is contraindicated? Now you tell me. I've already written in the slide. Please don't see the slide. Just listen to me and tell me. Will you give her some which medication is that you should avoid for a hypertensive patient? This is a must know. I think it is all in your fingertips or tips of your tongues. Even when I wake you up in the sleep, you'll answer correct. I'm sure of this. So hypertension, you should avoid. Mm-hmm. Anyways, it is in the slide. I don't want to show you, but still. Why am I not getting any replies? Slept off. Ergometrin, methergin. Yes, Nitish Patel gave me the first correct answer. Yes, methergin and the methyl ergometrin. This is the group of drugs we should avoid in case of hypertension. If the same history suggests that the patient is having asthma, then we should avoid carboprost. Okay, so these are the two important things that you should know in case of PPH medication. Yes, methergin is a big no, correct. So this is the very important thing that you should know. You cannot avoid to know this, or you cannot go to exam without knowing this. It is a must know. That's all. There is no choice in this. Okay. So next, coming to misoprostol, though this is also prostaglandin group, this does not cause any problem with asthma. So you can give misoprostol, no problem. So coming to the blood replacement, how do we give? 1:1:1 ratio. One, especially for a massive blood transfusion. When you're doing more than 4, she's lost more than 50% of blood, lost more than 4 transfusion within 24 hours. That means you should give 1:1:1 ratio. That is 1 blood, 1 FFP, 1 platelet. Okay, this is what you should remember. Okay, 1 blood, 1 platelet, 1 FFPs. Tranexamic acid can be added, and the other underlying causes like infection. Infection is more common in case of retained placenta. Infection you have to treat with antibiotics and correct the coagulopathy. Like if there is DIC or deficiency, you correct with FFPs and platelet transfusions. Okay. After oxytocin, if it is a firm uterus, bleeding is reduced and stable patient, that means it is effective response. So if that is not happening, so then your history they can give you. Okay, they'll give you that there is you have given already 3 groups of protonics. Okay, medical management. Still, it is not happening. So then you are trying to do this image. They'll give you. What are you trying to do in this image? Yes, tell me what is the image describing here. Usually in PPH, when it is happening already with your uterotonics, we already start doing this. Okay, what is this? If the uterus is very relaxed, the tone is not good, the uterus is very flabby, then we'll start doing this. What is this? Mhm. Yes, somebody answer me. Shruti, are you there? Okay. Uterine massage. What are you trying to tell? Okay, I'll tell it myself. This is massage. Okay, Shruti. Okay, fine. This is a bimanual compression. Okay, what we are trying to do here is bimanual compression. So, what do you understand by bimanual? Nothing is by heading in obstetrics. So, bimanual, one on the abdomen, one in the vagina. So, bimanual. Okay, so you're doing using 2 methods. Yes, they just gave me the correct answer first. So, this is the bimanual compression. What we are trying to do, one through the vagina and one from the upper hand. What we'll do, just like a manual compression between the this is the uterus uterus in between, one in the abdomen and one in the vagina. So we are pressing it, just like manually compressing it, so that the sinuses will not open up, it will get blocked. Okay, so this is our main aim. So once the sinus is blocked, slowly it will start reducing, our medicines would have acted by then. So, okay, that is the main aim. So this is usually the most common mechanical method that we do. When all these things fail, what is the most important mechanical method that we do, that I'm going to tell you. Okay, the different slide came. What is shown in this figure? Okay, again I'll show just the image. What is shown in this figure? So they'll give you a history now. You are in a PHC. You have delivered a patient who came to you. You have delivered a 3.2 kg male baby, whatever, at so and so time. And suddenly she started pouring. You gave uterotonics, but it is not acting well. In PHC, you do not have further facility for blood transfusion or exploration. So you want to what is send this patient what with the present instrument that or present photo, whatever I have shown you. What is the image shown here? Yes, I got Nitish Patel gave me the first answer. No, no. What is A's garment? Non-pneumatic anti-shock garment. Okay, anti-shock garment you want to say? Okay, fine. This is a non-pneumatic anti-shock garment. This is not pneumatic, just compression. It will prevent pooling of blood into the peripheries. It will help in the supply of the blood back to the major organs like kidneys, heart and brain, which requires major blood flow that moment. Okay, so it will help in the blood flow to the major organs, prevent pooling of the blood in the peripheries. So whenever you are referring a patient from a PHC to a tertiary care, it is advised to send with this garment, so that there is some amount of blood which is retaining into the liver, sorry, kidneys and the brain, so that there is no end organ damage that is going to happen. Okay, she doesn't go into multi-organ dysfunction. So next, coming to the surgical repair, you have done your medical method, it did not act well. So what is the image again shown here? Hmm. Mm-hmm. Yes, this is a balloon, Bakri balloon, which we use for a prevention of one of the mechanical methods. Okay, once your bimanual compression is failed, your uterotonics is failed, before surgical exploration, the first thing we use is Bakri balloons. Okay, this is most commonly used in case of placenta previa. Placenta previa, the lower segment uterotonics would not act much. Your ergometrin and ergometrin and carbopras does act. Oxytocin doesn't act much on the lower segment. Okay, so whenever we have lower segment bleeding, we usually use this. So this helps much easier and easy for us to prevent postpartum hemorrhage. Most of the patients improve with this when they fail with the medical management. Okay, firm uterus and persistent bleeding. Okay, what is your diagnosis? Uterus is still well contracted, but there is persistent bleeding. So you should go and check off. Mm-hmm. It is tear, correct. So some tear trauma which is causing the postpartum hemorrhage, then you should repair the trauma. Tissue removal, as we already told, if there is some retained tissue, you should do manual removal of placenta or evacuation of the retained products. If there is a uterine tamponade Bakri balloon or condom catheter that you want to use, then best uterus saving bedside procedure. Okay, so this also, if we, many PHCs are nowadays equipped with this. Okay, Bakri balloon. It is very easy to inflate the Bakri balloon and put it inside, inflate, and then you refer your patient also. It is very easy. Okay, more in non-pneumatic anti-shock garments and may not be available everywhere, so this usually is available and cheaper also, so easy for you, anyone to use it. Okay, that is why we should know such things which are life saving for the patient. That is why they are very common exam questions also. So next, coming to your Bakri balloon also did not help. Okay, so Bakri balloon also did not help. Next, what is your answer? What you want to do is the surgical method, that is your first comes with uterine saving surgeries, but that is B-Lynch surgery, Cho's quest sutures or Heyman sutures. So this is the B-Lynch procedure. Many times this photo also has come in the exam. Okay, so these photos are very important. Okay, so most of the photos in exam comes from DC Datta textbook. So just revise your book once before you go. So there you can see the images. Same images are usually replicated in the exams also. Okay, so here you can see in first we'll enter from the lower segment anteriorly, then upper segment, go back. 3 is posterior, 4 is posterior, then again go back, come to the anterior. 5 is anterior on the other side, 6 is anterior on the same side, and then you will tie it up here. Okay, so this is B-Lynch sutures. If there is no uterine insertion or the uterus is already sutured, that makes it Heyman suture. Okay, so this is the basic difference that you should know. B-Lynch, Heyman's and Cho-Square sutures you should know. Okay, by names. These are the surgical methods of prevention. So coming to the hysterectomy becomes the last resort. Okay, when we do not have any other choice, then hysterectomy becomes the choice. Now coming to the other procedures before hysterectomy, what all we can do? We can do uterine artery ligation, stepwise devascularization. Okay, pelvic devascularization is stepwise devascularization. Okay, after your surgical method B-Lynch also fails, then you will go for first option is uterine artery ligation. In stepwise, as you can see in this image, the first you do is uterine artery, then is ovarian uterine anastomosis, and last is your internal iliac artery ligation. So internal iliac artery ligation is only the anterior branch that you will ligate. Okay, why we ligate only the anterior branch? Because posterior branch is a end branches. They do not have any anastomosis. All the anterior branches have anastomosis. That is why we ligate the anterior branch of internal iliac artery. Okay, they can give you an image of this where you ligate. So this is the bifurcation. Okay, this is internal iliac artery, this is external, internal. Okay, so in internal, from the bifurcation you will come 3 centimeters below. Okay, this number you remember for exam sake. So you will come 3 centimeters below. Okay, and then you will ligate. Why do you come at the from the bifurcation 3 centimeters below? So that we avoid the posterior branches. So posterior branches are the end branches. There is no more anastomosis for that. By mistake, if you ligate even the posterior branches, then there will be gluteal necrosis and all. Okay, so that is why we do not do that. So what do we do is ligate it, 3 centimeters will come down, and then we'll ligate only the anterior branch. Okay, then what is the main reason for reduction in PPH following this uterine artery or all these ligations? It is the pressure. Okay, the pressure in the uterine artery will reduce. Okay, this will cause reduced blood flow, more clot formation, and reduced postpartum hemorrhage. Okay, this is the basic things that you should know. Okay, lastly, coming to a uterine artery embolization. So embolization is done by whom? Obstetrician. Okay, it is done by a intervention radiologist. When you have a facility with an intervention radiologist, you will use uterine artery embolization. Where do we do this uterine artery embolization? Is where we already suspect. For example, it is a case of placenta previa. We are suspecting accreta, percreta and all. We are very sure she will have bleeding. So that time you can already keep the catheter in situ. You can inform the intervention radiologist and make sure you know they know the case, and they will come and they will do the insertion and keep it. Once the cesarean is done, or if there is bleeding, they will insert the polyvinyl alcohol. Okay, the PVC, when they put this polyvinyl crystals or alcohol, that time what will happen? This will go and block the uterine vessels and for a temporary period and reduce the blood flow to the uterus. Okay, so this one. So last resort would be your hysterectomy, where it is uncontrolled, accreta is there or ruptured uterus has happened. In such cases, we may end up doing a hysterectomy. It becomes a life-saving procedure for the patient. So this is about postpartum hemorrhage. Okay, everything you should know. Medications you should know. You should know about the first step, next step, last step. What is the next best step? They can give you at any level of the question. You should be able to pick up and answer it. Okay, so that you will know the sequence. We have given you everything. Okay. Okay, now coming to this set. So this is I'm expecting new questions also like this. This they can give you a tray of instruments, tell what procedure is planned for this patient. So like this. So the different instruments that we use also you should know. Okay. So what is this instrument? Let us start from here, from the right corner like this. Okay, from right corner to the left corner. Okay, what is this instrument? Yes. They can label the instrument and give you, or they can give you a tray, what is the procedure planned. They can ask you, give you a single instrument. So I didn't want to keep multiple photos and take a lot of time, so I've kept in a single image. Now you will tell me what is this image. This tray is for what you already saw the heading, I think, no? Mm-hmm. Tray is already for sponge holder, yes. D S, give me the first answer. This is sponge holder. The tray is episiotomy tray. Okay, what is this suture material? What we use for episiotomy? Yes, Shruti also is correct. Mm-hmm. They started going again. Okay, this suture material is chromic catgut. Okay, so chromic catgut is the suture material we use. Okay, it is a absorbable suture material that we use. Next, coming to the, yes, no, Vicryl is purple in color. Okay, for you to remember, Vicryl is a delayed absorbable suture material. Vicryl is usually not used in case of episiotomy. What Vicryl we use is rapid Vicryl. Rapid Vicryl can be used, but not regular Vicryl. Regular Vicryl we use if there is tears, third and fourth degree tears we use. Otherwise, we do not use Vicryl. Catgut is commonly available in government hospitals. Rapid chromic catgut is what we use, and rapid Vicryl is available in corporate setups. They can ask you both of them. They're absorbable sutures. Delayed absorbable becomes Vicryl. Okay. So next, this instrument is what? Yes, somebody has already answered me. This is a episiotomy scissors. Very good. This is a toothed forceps. This is what? Now you will tell me what is this. Mhm. Proline is a non-absorbable suture material. We do not use proline here. Where we use in cesarean, maybe if we are having a scar where we are thinking this scar deficiency can happen, or incisional hernia can happen, or scar infections are very common, there we use proline. For cesarean skin closure, nowhere inside the abdomen we use proline as such. Maybe we can use if there is multiple surgeries for rectus sheath to prevent herniation, but otherwise proline is a non-absorbable suture. We don't use in episiotomy repairing. Yes, very good. Nitish Patel gave me the first answer. This is the needle holder. Very good. And the syringe, why do we have two syringes here? Okay, this is a lignocaine, the local anesthesia. One more maybe for the cord blood sampling. Okay, usually they do cord blood sampling. Yeah, what is this? Very common and easily answerable question. Uh-huh. Sim speculum, yes. Nitish is on fingertips. And what is this last? Yes, this who will answer is read or attended the deliveries. Now we'll see who has attended deliveries maximum. Sims, yes, Sims is answered already. Sim speculum is done. Suddenly the messages stopped coming. Till now they were coming so many messages. Needle holder, lignocaine, Sims. So this is a, yes, 1%. Artery forceps. Yes, you can take it as artery forceps or a Cocker's forceps. Since it is closed, we cannot see the needle tip or the hook in the front. Usually we have a Cocker's forceps to clamp the umbilical cord. Okay, so this is for the clamping umbilical cord. Yes, artery forceps also you can answer, no problem. If they've shown you a hook in front, then it becomes a Cocker's forceps. So that will be something like this. Okay, in the tip there will be a hook like this. Okay, so that becomes a Cocker's forceps. Okay. Very good. So next, coming to this. So this I had taught you in my class, in my regular revision classes, quick revision session, and also in your what you say regular digital classes. Yes. So after episiotomy, how do we repair? And this I had given you, and this was your NEET PG 2025 question. Now you'll answer me the answer for this. When repairing a mediolateral episiotomy, what is correct sequence in which the tissue should be sutured? I'll skip that slide. I'll show it back to you once again once you answer this. A. Okay. Yes, Shruti gave me the correct answer first, then is the Nitish Patel. Okay, Anna, so whatever your name. See, whenever we are suturing, we start suturing from the mucosa first, not from the skin. If we close off the skin, how will we reach the muscle inside? Isn't it? So we cannot suture from the skin. It is always vaginal mucosa first. Okay. First we'll suture the mucosa, then go for the perineal muscles, and lastly skin will be sutured. If there is a tear, let us say anal mucosal tear, or if there is a internal external anal sphincter tear, so first we'll suture the tear and then go for mucosa, then go for the or you can suture the mucosa, then the tears, all the muscle layers. Okay, but always mucosa and the tears come first. Never skin come first. Okay, so skin can never be the answer. D. Who answered D? Okay, muscle is also never first. Always mucosa first. Okay, first is mucosa. Even if there is a tear, you can suture mucosa and then this tear, or you can suture the tear and then mucosa hand in hand. It's okay. But mucosa is always the first choice when we are doing a normal episiotomy repair. Then comes your perineal muscles, then comes your skin. So if they give you a question now exam for the tear repair, so you will tell either first mucosa or the tear repair first. Okay, no, never the perineal, never last. Okay, it is always first you should suture these things. Why we suture mucosa first is, otherwise in tear I'm telling, before suturing the tears, at every case mucosa is first you can keep, because mucosa is the one which bleeds a lot. So once we suture, we also have a clear field to do the suturing. That is why. Okay. Now coming to the forceps and vacuum delivery. So we have a small time for all these things. So we'll do a quick revision of all the delivery mechanisms also. As far as I can, I will cover in the class. Okay. If you still want an extra live class, please message me. I'll try and accommodate somewhere in the later stages. So coming to the forceps class, so here in forceps, they can give you different types of forceps, parts of forceps, curves of forceps, all these things. You know what is the blade, what is a shank, what is a handle, what is a lock, and what is a pelvic curve, what is a cephalic curve. This much you should know. Okay. Next, coming to the types. So this is a outlet forceps, which we can use. That is Wrigley's forceps. This is mid cavity forceps, Simpson forceps. This is Keelan's forceps. And what is this? Yes, tell me what is this. Who will answer? Let me see. Who will give me the first answer for this? What is the last image? I think if I do like this, that also will come off, but it didn't come. So since it didn't come, it is a question now. Killen's already I've showed you, no? This is Killen's mid-cavity forceps. This is outlet forceps. That is your most commonly used Wrigley's forceps. If they're given you station +2 and below, you use Wrigley's forceps. Which forceps you want to apply? Then if they're given station of +2 and below, then you will tell I'll use outlet forceps or Wrigley's forceps in the exam. Okay. Now coming to the outlet also obstetric forceps. So all are obstetric forceps. So you can see the long shank here, isn't it? So this shank blade and handle, this shank is long. Which one will have the long shank to accommodate full body of the baby? So I've given the maximum clue. Mm-hmm. Okay, let me slide it down. I don't think you answered it. So it is a Piper's forceps. So see the images. These are tentative questions in your exam. Okay, again, I'm clearing the screen so you can take a screenshot of this and remember, keep it as your favorite photos, last minute revision photos. Okay, these images. This is a Piper's forceps. Where do we use Piper's forceps? After coming head, that is in the breech presentation. Okay, the head is coming late, so that's why I told you full body should accommodate on that, isn't it? So that is the reason we use Piper's forceps in the breech or the after coming head. That is why this has a long shank. Okay, so accommodate the full body of the fetus. Still nobody answered. So sad. Okay. Now coming to the correct application of forceps. When do we say it is forceps is correctly applied? What is the position? It is bimalar and biparietal. So forceps should be applied like this. Okay, the way for the fetus. So I've shown you this image. They can give you this kind of application is done in forceps. What is the application called as? It is bimalar. This is your malar prominence, isn't it? So bimalar, biparietal. So bimalar and biparietal forceps application. This is the normal application of the forceps. And your sagittal suture should be in the mid plane. There should be no more than one finger placed between the forceps and the fetal head. It should lock easily. Easy traction should be there. These are the common things that you should know. Okay. Next, coming to the vacuum. In vacuum, the most important point is the flexion point. So what is flexion point? It is the center of the cap, the center of the vacuum cup. Where should it lie? That is the flexion point. I'll write it here only. So if this is the fetal head, this is the anterior fontanelle, this is the posterior fontanelle. Anterior fontanelle is diamond shaped, right? So this is the anterior fontanelle. I'll draw it little bigger. So this is the fetal head. This is the anterior fontanelle. This is the lambdoid shaped is the posterior fontanelle. Okay. So now, where is the flexion point? The center of this cup should lie where is the flexion point? Okay, it is either 3 centimeters anterior to posterior fontanelle or 6 centimeters posterior to anterior fontanelle. So this wordings becomes confusion. So that is why I've given you like in this figure. Okay, so you can remember it is 6 centimeters behind the anterior fontanelle, 6 centimeters posterior to anterior fontanelle, or it is 3 centimeters anterior to the posterior fontanelle. Okay, so you understood this? Yes. So 3 centimeters above posterior fontanelle. Phoenix has given me the correct answer. Yes. But what happened in exam is they would not always give you 3 centimeters anterior to posterior fontanelle. They would sometimes give you 6 centimeters behind the posterior fontanelle. I think I have that question also ahead in for you. So that is the reason you should know both of them. Okay. So this point is where the cup should be placed. The center of the cup should be in this place. Okay, so that is the flexion point. So the center of the cup should be here. Why we put it there only? Because when we apply that exact position, we can maintain flexion of the fetus. We want the head to be in a well flexed position, isn't it? So to maintain well flexion of the fetal head, it is very easy. That is why we apply it only there. Okay. So what is this that is shown? This is a chignon because of the vacuum pressure. Okay, so this is a chignon that is shown in this. Okay, normally vacuum is safer for whom and forceps is safer for whom? What is the advantages of each of them? Yes, tell me. Forceps you can apply for non-cephalic presentation also. Can we apply for vacuum for non-cephalic? It should be only cephalic presentation. It cannot even be a face presentation. Only head. The head should be there. Okay. It cannot even be a face presentation. Only head. Only cephalic presentation. Non-cephalic presentation, forceps can be used, but not the vacuum. Vacuum is only for the cephalic presentations. Next, coming to the term of the baby. Can it be used in preterm labor, forceps? Yes, preterm labor we can use forceps, but preterm labor we cannot use vacuum. We cannot use. Why? Because we do not know the clotting factor structures for the baby. There is very high complications, tear of the fetal scalp and all. So we do not use forceps there. Okay, then coming to the application, which is easy compared to forceps and vacuum. Which one is easy? Easy is vacuum for sure compared to this has a more learning curve is increased in this, but success is always more with forceps compared to vacuum. Successful vaginal deliveries are more with forceps than with vacuum. Not that vacuum is not having, but compared to both, if when a well trained person applies a forceps, it is easy, faster, comfortable, and they deliver very nicely. Okay, with forceps. But only thing is forceps requires a more learning curve. Vacuum is easy to learn also. Okay, this is what you should know. Okay. Next, coming to breech. Yes, what is breech? You should know. First is the positions of the breech. What is a complete breech? What is an incomplete breech? What is a frank breech? This is a must know question. Okay, so you can keep it for yourself. Universal flexion is there. It is a complete breach. Okay, whenever there is a universal flexion, okay, then that makes it a complete breach. Now, any one of the limbs are extended. Let us say knee is extended, hip is extended. That makes it a incomplete breach. So if both hips and knees are extended, then that makes it a frank breach. So this incomplete breach, it is the extended foot. Okay, the knees is down, and sorry, in frank breach, hip is flexed. Hip is flexed and knee is extended. So it is nothing much to by heart. You just can imagine and you can tell this answer. So what kind of breach is presentation is this? So what is this? So frank breach, the limbs should be splinting to the face of the baby. This images, if you remember, it is more than sufficient. If you have any doubts in this, you please message me. I will try and clear it up. So footling of these is more of these breech presentation. Footling is one of the most complicated one. Why? Because first of all, footling, no vaginal delivery. Frank breech and complete breech in a multi, you can give a vaginal delivery trial. But if it is a footling presentation, there is a complete no for a footling presentation. Okay, because foot is small, it will come off even with smaller dilatation. Rest of the body parts will get stuck. Okay, so that is why footling is never a for a vaginal delivery. And whenever there is footling presentation, always more common chance of having a cord prolapse in such cases. Okay, so you should remember. So you should remember footling always LSCS, footling always increased chance of cord prolapse. Okay, so these two are very important things that you should remember. Okay. Yes, yes, I'm going to teach you the manuals also. I was asking between if you have any doubts on forceps and vacuum, you can ask me. So coming to the management, whenever they've given you a history, breach is there, 36 weeks patient or 37 weeks, your first management or trial should always be for external cephalic version. If the patient, all the features are normal, everything is normal, you should always try for external cephalic version. In primary, you can do it at around 35 to 36 weeks, whereas in multi, you'll do little later stage, 36, 7 to 38 weeks. Why in primary we do early? Because in primary engagement happens of early, whereas in multi engagement happens latest date. That is why. And if you do it very early, what will happen? It will rotate back to breach. If you do it very late, you won't be able to do it. That is why we have this period. What is the success rate of external cephalic version? 65%, and failure rate is 35%. Okay, this percentage they might not ask since they're not asking numerical and memory based questions much in clinical subjects, but still you should have a some amount of control over this also. Okay, and vaginal delivery is when you want to do a external cephalic version, only whenever we have the very high chance of having vaginal delivery. Spontaneous delivery, assisted breech delivery you can do, or you can do total breech extraction if still it is a breech only. Then you can do a cesarean delivery. I'll tell you indications in breech for cesarean. Next slide. So the procedure, this photo also I want you to remember. First is remove the baby from the pelvis, then in move it in maintaining the well flexion of the baby. You can see they maintain the flexion of the baby. Okay. No, previous LSCS as such is not a contraindication for external cephalic version. Previous one LSCS is no more contraindication for vaginal delivery, for external cephalic version, nothing. Okay. But now previous LSCS is as simple as primary or something like that, because so many cases are there with cesarean post LSCS now. Okay. So many trials have happened. There is no contraindication as such. When there is good liquor, the scar thickness is good, the placenta is situated up, there is no problem. Previous LSCS, placenta previa, all these things, abruptio placenta, short cord, oligohydramnios, frank breech, all this becomes a relative contraindication, but not previous LSCS. Okay. Now coming to the rotation, we can do first is maintaining the flexion. So this image is shown so that you will remember and recall in your exam what procedure they are doing. So whenever they are doing from the abdomen, that becomes an external cephalic version. So what they do internally is this photo. Okay, when we do it PV via vagina, then it becomes internal podalic version. So externally when we are doing, we want the head to come down. Okay, so delivery is easy. When we are doing internally, we want the buttocks to come down so that we can extract the baby faster. So when do we do internal podalic version? for twin 2. Okay, twin 1 is delivered, the cervix is fully dilated, so there is no problem now. The twin 2 also will come out. So twin 2, let us say it is in transverse lie, you are not able to get it. So you can hold the foot of the baby and you can grasp the foot of the baby like as shown in the image. Go to the baby, hold the foot of the baby like this and grasp the foot and get the baby down like this. Okay, so this is done only modern obstetrics. Only indication for internal podalic version is delivering of the twin 2, which is usually either in transverse lie or slightly oblique lie, or the engagement is not happening, that time we can use this. Okay, delivering a twin 2, this indication also you should know. Okay, then coming to mechanism of labor in breech. Okay, so breech here it is crowning, or you can say it as climbing. Okay, so head is crowning, breech is climbing the pelvis. Then the first posterior buttock and anterior buttock would deliver. So it hinges behind the pubic symphysis, then it squeezes and one of the buttock delivers. You always will maintain the buttocks or the back anterior in case of breech delivery. Okay, so now comes to the Pinard's maneuver. Somebody asked me the question. So you can see the photo here. Actually, this photo is got reversed. So this is first image, this is second, and this is third image. Okay. So first, the buttocks have come out, then your limbs are not coming. Maybe because it is a frank breech as shown in the first here, this image. So you will put your hand, try and press. It is frank. You cannot reach till the head of the baby. So what you will do? You will try and press on the popliteal fossa. P for popliteal fossa, P for Pinard's maneuver. So you can remember like this, correct? No, so I know all these mnemonics you already know since you have attended many classes. So P for Pinard's and P for popliteal fossa. So you will press on the popliteal fossa and the foot will come down. Okay, when you press, you can do it for yourself also and see. When you press on the popliteal fossa, flexion is there, then there is foot that is coming down. Then you will grasp the foot and then you will draw the foot out like this, and delivery of the baby as lower limbs will happen. So this is the Pinard's maneuver for delivering of the extended legs. Okay, just a second. Okay, so now coming to the delivery of the arms, the maneuver that is Lovset's maneuver. This is also one of the important rotational maneuver. You just the posteriorly the shoulder would have come down compared to that of the anterior. So when we rotate it, the posterior shoulder anteriorly, it will come below the pubic symphysis and you can extract the shoulders easily. So this is the basic concept of the principle behind this maneuver. So when they are trying to deliver the shoulders of the baby, that means they are delivering by the Lovset's maneuver. So you should know all the names, all the figures. This is what is your main aim. Then comes to the delivery of the head, the most common always asked question, the Burns Marshall. So I'm not going to demonstrate the procedure and all for you. I know you all know this since you're already well thorough with your exam preparation. So Burns Marshall, you'll hold the foot of the baby and do the hyperextension of the baby over the maternal abdomen. Then there will be flexion and delivery of the head. So remember, in case of delivery of breech, head is delivered in flexion, whereas in case of delivery of the head in cephalic, head is delivered in extension. Okay. Then this is Burns Marshall. This is Mauritius Maliviet method or modified. When we don't put hand inside the mouth, that is the modification. We'll put on the chin and two fingers on the malar prominence. You will maintain the flexion and deliver the fetus. You can see the reels also on my Instagram channel, which will demonstrate all three procedures. One is Burns Marshall, and I have demonstrated the Pinards, I have demonstrated Lovesets, and I have demonstrated the Mauritius Maliviet also. Okay. Then comes the Piper's forceps, which I told you initially. So this is the Piper's forceps, which we use to the delivery of the, there are three mechanisms for delivering the fetal head. These three you can know. They can give you, which among them is not the mechanism for delivering the fetal head. They can give you Lovesets, they can give you Pinards. I'm sure you'll answer this question also. Okay, so you understood this. This is the way we'll put the same application, just like the same forceps we apply, same way. Make sure that the fetus is held with a towel and the body is not hanging down, and then you will apply and then the rest it on the shank since it has a long shank. Okay, now you'll answer me this question. Since I have spoken so much for so much time, now you will speak out. Okay, a gravida 2 para 1 living 1 woman experiences umbilical cord prolapse during labor. The cervix is 5 centimeters dilated and the healthcare provider feels that the pulse of the cord can feel the pulsation of the cord. What is the immediate next management? Okay, now the delivery has happened and the cervix is 5 centimeter, sorry, the labor is started and the cervix is 5 centimeters dilated, and there you can see the umbilical cord with pulsations. Yes, what you will do? Option A, reposition the mother with her hips raised and fill her urinary bladder. Continue to observe the labor progress without intervention. Gently push the cord back into the vagina and pack it. Administer oxytocin and speed up the delivery. Mhm. Yes, let me see what you'll answer. Mhm. I've got so many answers, but not the correct answer. I am very sorry to say none of you gave the correct answer as of now. If anybody wants to change the answer, you can change the answer. Hmm. Hmm. Okay, fine. Nobody is giving me the correct answers. Everybody is wrong. So we will explain it to you now. So the cord prolapses happen. Okay. So the cord is prolapsed. Now the head is here. Okay. What will happen? First answer. Let us say. Okay. Shruti has given me the correct answer. Very good. Hmm. Now, cord pulsations are there. Means what? Baby's heartbeat is still there. Okay. Baby is alive. Okay, they say baby is dead or scan said no FHS or there no cord pulsations, then you will see. Okay, even if there is no cord pulsation, you should confirm it by NST, Doppler, ultrasound that there is no heart rate. Okay, then only you will manage. Now they have given you a case with cord pulsation is there. That means heart rate is there. So let us see what option D use there. You will administer oxytocin and speed up delivery. So this head will keep on compressing from 5 centimeters to become 10 centimeters. What is the minimum duration it will take? It will at least take for her to deliver next 5 hours. Can the cord be prolapsed, exposed to the external environment and still be active and supplying the blood? Will it not undergo vasoconstriction because the cord vessels are exposed to the external surface? Yes, it will undergo vasoconstriction. It should be in its own environment. If it's once it's out, it will undergo vasoconstriction, isn't it? So it will undergo vasoconstriction. There is no blood flow to the fetus. Next 5 hours can we wait? So directly this goes as no, isn't it? So that you cannot oxytocin. And when you give oxytocin, head is more and more compressing. It is coming down more and more compressing on the cord. Cord is getting compressed. So there is no blood flow to the baby at all, isn't it? So this option is no. Next, gently push the cord back into the vagina. This is one thing which you should never do. Even if cord is prolapsed in the vagina, let it be in the vagina, no problem. When you touch it, more stimulation, more vasoconstriction. Okay, so that's why you do not handle the cord. You do not try to put it back. The more you put it back, more vasoconstriction, more fetal distress, more damage to the baby. Okay, then continue to observe the labor progress without intervention. You are a doctor. You cannot leave the baby cord is prolapsed. You cannot just wait and watch whatever happens and just sit and see. You have to do some intervention, isn't it? So this is absolutely no. For all these things are absolutely no. You should not do any of them. Okay, they are like contraindications. So what you should do is reposition the mother on the hips. That means like all four positions, like that position you should make a set. What will happen that time? Head will go up. When you fill the bladder also, head will go up. That means the head no more compresses on the cord. There is blood flow maintained to the cord. Meanwhile, shift her to that of the OT and do immediate cesarean section. Okay. Whenever there is a cord prolapse and you do not intend to deliver in next 20-30 minutes, like that means head is fully cervix is fully dilated, head is down, you can apply some instrument and deliver in next, like category 1 cesarean section is 20 minutes, so you will deliver her in vaginally only next 20 minutes, means only you can wait, otherwise you cannot wait. You have to do immediate cesarean section. You are saving the baby is also equally important, isn't it? So by the end of the labor you should have a healthy mother and a healthy baby. Okay, next question. I'll read it out or you'll read it for yourself. Okay, I'll read it out. A primary gravida who's experiencing a rapid labor during transport to the hospital. Okay, she delivered like precipitate labor, rapid labor, and presence with the following observed injury. What is the type of perineal injury most likely? Okay, Phoenix has given me the answer saying it as third degree. Shruti is saying it as fourth degree, third degree, second degree. Okay, fine. So let me explain you the structures now. I only showed you that time the mucosa, tears, and things like that. So I'll explain you the structures now. So what is this? This is the vaginal mucosa. What is this? This is the perineal muscles. This is the internal anal sphincter. This is the external anal sphincter. This is the rectal mucosa. So everything is cut. Now you tell me the stages as grade. Did I tell you, show you the slide or did I give you the question beforehand? Okay, I've not told you about the grades of tear, no? Okay, fine. No problem. So amongst this, Shruti has given me the correct answer, that is fourth degree. So since you can see in the image, there is a tear on the vaginal rectal mucosa also. So the white one, what they have shown is a rectal mucosa. There is a tear on the rectal mucosa. There is tear on the external anal sphincter, internal anal sphincter, and the perineal muscles, mucosa, everything is torn. So that means it is a grade 4. Okay. Next, coming to the indications for cesarean in breech. Whenever the fetus is very large, more than 3.5 kg, head will get stuck, known to breech delivery vaginally. Hyperextended fetus. That means it is called as star-gazing fetus. So star-gazing means what? The egg is hyperextended. So that's why they're just watching the star-gazing. Okay, so that's how you should remember. You should never by heart anything. Whenever there is a star-gazing fetus, you do not do a normal delivery. Why? It becomes mento-vertical diameter when it head enters into the pelvis, which is no diameter as big as that in the pelvis. That is why. Footling presentation. Why we don't do? We have already explained you. What is the most common complication in footling presentation? Yes, it is cord prolapse. Any degree of contraction or unfavorable shape of the pelvis, previous perineal injury, death or child trauma, injuries, birth injuries, maybe birth asphyxia, any injury to the baby, and uterine dysfunction. It is not a spontaneous well progressed labor. So coming to the third stage of labor now. Okay, in third stage of labor, it starts after the delivery of the baby till the delivery of the placenta, isn't it? So what are the three important signs of placental separation? Yes, first is whenever the placenta gets detached, there is a sudden gush of blood. Okay, sudden gush of blood. Placenta separation is there, then sudden gush of blood comes out, then there is a suprapubic bulge, then there is a pseudo lengthening of the cord. So these are the three important features of placental separation. Okay, so first the placenta gets separated, then it will descend down, then it will get expelled. Okay, what they are doing in this procedure, this is also most commonly asked question. Or your active management of third stage of labor, AMTSL, is also very important question. Okay, it has three important steps. One is delayed cord clamping. Okay, don't forget these steps. Delayed cord clamping. Okay, you should not clamp the cord immediately after delivery of the baby. You should wait either till the pulsation is lost or not there, or at least 2 to 3 minutes before clamping. Then is the uterotonics. So previously we used to say IM or IV oxytocin, but now they've added you can either give carbetocin also, because it is very good compared to that of the carbetocin is better, or the recent Foxy says carbetocin instead of oxytocin. Okay, so you can use carbetocin in your options. You have a carbetocin, please take the carbetocin option. Then comes your last one, that is controlled cord traction. So controlled cord traction, also called as modified Brand Andrew technique. Okay, Brand Andrew technique. So this is also equally important, as important as both of them. Controlled cord traction, the image that is shown is here. This hand of the person is doing the control. It is preventing the inversion of the uterus, which is the most common complication, because uterus has suddenly become flappy. No, it will get inverted if you pull it, which is not contracted means. Okay, so that is why you will push the uterus up, prevent the inversion of the uterus, and then gently do the cord traction. Okay, gently give a cord traction from your dominant hand, and with your non-dominant hand push the uterus into the abdomen. Do not, prevent it from inversion. So why do we do delayed cord clamping? What are the advantages of delayed cord clamping? So what will happen when you do not clamp immediately? Almost 60 to 80 ml of blood, it is almost one third of the baby's blood will come into the baby. Okay, it will prevent early anemias and blood loss in the fetus, helps very good in the baby's development. Okay, so that is why delayed cord clamping is very important for the baby and for the mother. Since so much blood is going off, it will reduce the placental mass also. Okay, size of the placenta also, so we will have the time also, easily it will get expelled. Then uterotonics helps to contract the uterus, helps to separate the uterus, and controlled contraction helps in the spontaneous expulsion or assisted expulsion of the placenta. Okay, these are the very important things that you should know. Then comes to the manual removal of placenta. So this image also they can give you. Since last exam they have given you control contraction, now they can give you manual removal. So how do we go? Along the umbilical cord you will go till the placenta, and then you will find the edge of the placenta. In the edge of the placenta you will do the slicing movements as shown in this image. You will do the slicing movements, and then you will separate the placenta, and then you will grasp the placenta in your hand which is inside, and you will get it out. Okay, this is the manual removal of placenta. So this classification I had to show you before. I am sorry I've shown you late. Okay, so this first degree is only injury to the skin. Okay, first degree perineal tear, only injury to the skin or small mucosal injury. And second degree tear is your episiotomy. Okay, it is a planned surgical incision which is a second degree perineal tear. Here we injure the mucosa, vaginal wall, and the perineal muscles and the skin. Okay, all three are cut. And then your third degree is again having classification. 3A is less than 50% of the external anal sphincter injury is there. 3B is more than 50% of external anal sphincter injury. 3C is both external and internal anal sphincter injury. This is a must know also. Okay, most commonly they have asked you or described you or given you an image showing the damage and asked you question. And fourth degree, when there is involvement of the external anal sphincter and also the rectal mucosa is involved, as I had shown in the recent exam question. Okay, where rectal mucosa also is involved, anal epithelium or the rectal mucosa along with the sphincter injury is there, that means it is a fourth degree perineal tear. Okay, so this is about the postpartum immediate. Now coming to the shock. Okay, shock also they'll give you history based question. Okay, they'll give you a history. They'll ask you what is this? It is an obstetric shock. You will have to diagnose is it because of PPH or what you want to do next. Okay, most common cause for hypovolumic shock is postpartum hemorrhage, hematoma, broad ligament hematoma or paravaginal hematoma. It is also a type of postpartum hemorrhage, but it is not revealed. We are not seeing the blood loss, but it is getting collected inside. Broad ligament hematoma and paravaginal hematomas. Neurogenic shock. Where do we have neurogenic shock? Whenever there is uterine rupture or uterine inversion, sudden vasovagal shock will happen. Okay, this is the neurogenic shock. Then coming to the obstructive shock. Okay, air embolisms. Okay, air embolism or amniotic fluid embolism is more common immediately after delivery. Okay, within 30 minutes she is delivered vaginally, everything was fine. They'll give you 1 hour later she is gasping, she is not able to breathe, and there is tachycardia, hypotension, all these things. Then it is amniotic fluid embolism. Okay, anaphylactic shock, mostly amniotic fluid embolism, and also you can see in case of anesthetic complication. If whenever there is anesthetic complication, most common reason for anaphylactic shock is anesthetic complication. Then is your septic shock. Whenever there is in your history, they give a history of prolonged rupture of membranes is there, or retained placental tissue is there, manipulation or instrumentation has been done, and that time antibiotic cover is not there, foul smelling discharge, which is having recurrent fever, then she is in septic shock. Okay, Coming to the management, they would not ask you in detail about the management. Most important thing that you should know is to treat the acute cause. For example, if you have diagnosed it at PPH, treat for the blood hypovolemia, neurogenic like inversion is there, then treat the inversion like that. Okay, so management initial steps are always ensure the patient airway and 100% oxygen is there. Okay, these are the initial steps. Control active bleeding, IV fluids, crystalloids, colloids until you get your blood, and IV sodium carbonates or for acidosis, and antibiotics for sepsis. Others like steroids and morphine and ranitidine for the supportive care. Monitor the pulse, ECG, BP and urine output, serum electrolytes and central venous pressure and ABG regularly. So now this is your one of the NEET PG 2022 question. Yes, tell me what is the answer for this question. On postpartum day 2, where is the level of the uterus usually located? Uh-huh. Now you will answer me first. Yes, Shruti. So immediately after delivery, where will the uterus be? Until what day will it be there? And will it start reducing from what day? Yes, Amruta Varshini has given me two finger breadths below the umbilicus. Okay, one finger, four finger, three fingers. See, so immediately after delivery, uterus will be just below the umbilicus. One finger breadth below the umbilicus. Okay, it will be just below the umbilicus, and it will start reducing after 48 hours. That means after 2 days. So on day 2, it will still be one finger below the umbilicus. So first 48 hours or day 1, it will be one finger below the umbilicus. Okay, immediately after delivery, uterus is well contracted and retracted. So when will it starting involution? After 48 hours. So after 48 hours, it will reduce by 1 to 1.5 centimeters per day, and it will go by another 6 to 7 days. It will go into the pelvis. Okay, so this is how it will reduce. So it will not reduce immediately after delivery or within 2 days. So first 2 days, it will be just below the umbilicus or with just one finger breadth below the umbilicus. Okay. I hope you understood. So next question. So next is a twinning phenomenon. So this is maximum that I wanted to cover today. But since in 4 hours I could not complete full of obstetrics for sure. So that is why I have included some important topics that they can ask you. What is shown in this figure? This is a twinning phenomenon. Within 3 days, if there is division. Okay, within 72 hours, within 3 days if there is division, it is dichorionic diamniotic. Correct? No. So it is dichorionic with less than 72 hours. It is DCDA twins, the most safe twins. Okay, this is the most safe twins. Then comes your 4 to 8 days or 4 to 7 days actually. 4 to 7 days. Then this becomes monochorionic diamniotic. So after 8 days, between 8 to 12 days, it will become monochorionic monoamniotic, the most dangerous ones. More complications are in this, but dangerous is this. Okay, and then after 13th day, if there is division, it becomes a conjoined twins. Okay, so this is what you should know. So this they can give you image what is happening, what day was the division, based on the image which day did you think the division happened, all these things they can ask you. Okay. So these are the common images, multiple places. I'm sure you have seen these images. So what is seen in this? Okay, you will tell me now what is seen in these two images. I will label it as first image and the second image. What is twin? I mean, what type of placentation is seen in twins of this first image and second image? Yes, you write it as one. What type of twin? DCDA, MCDA, MCMA, or two, and what type of twin it is? Then I will tell you the explanation. Mm. Twin peak sign. Okay, this is for the first image, is it? Nitish Patel gave one is DCDA. Yes, Aisha gave me the first answer. Nitish gave the answer, but he did not tell for which image he is he mentioning. One is DCDA, Aisha, correct. Next. Two is. Yes, it's not so difficult. Lambda sign. Yes, Nitish, you are right. But for which image? One or two? Mm-hmm. Yes, they just gave the answer for the second one first. That is T sign. Okay. So now you know this is the lambda sign. You can see it is like this. This is the lambda sign. Correct, no? So lambda sign or twin peak sign, this is seen in DCDA. Everything they answered. So nobody answered it in the flow, that's all. So one is a DCDA twin because it has a lambda sign or twin peak sign. Whereas this is a T sign. Here you can see it is like this. There is no bulge at the base of the placenta. So this is the T. So here it becomes a monochorionic diamniotic. Okay, so this is how it looks. So now you can see in this last image there is no amniotic differentiation also. This becomes monochorionic monoamniotic. So you understood? How do we see this? MCDS 2. Yes, now everybody's answering. Okay. So the first image is the lambda sign or twin peak sign. Everything Nitish told me except telling it was for the first image. Okay. So it is commonly seen in the DCDA twin. Okay. So it is DCDA twin where we have this bulge at the base of the placenta. So if this bulge is there, that means this is a lambda sign. So this lambda will help us to tell what type of twinning is it. So what type of chorionicity or the placenta it is should be usually assessed within 14 weeks of gestation. Later date placental fusion would happen. That is why we would not be able to get an accurate result. So that is why we should check what is the chorionicity in the first trimester itself, ideally before 14 weeks. Okay. So coming to the Quintero's classification, imagine this photo in your exam. Okay, so first there is just oligopoly. One baby is having polyhydramnios, one baby is having oligohydramnios, but both the baby's bladders are seen. Okay, no problem. Both the baby's bladder is fine. That means renal function is fine, blood flow is fine, the bladder is fine, but there is oligo and poly. Whereas in stage 2, what will happen? The bladder of the receiving twin or the oligohydramnios twin is not there. Okay, so whereas in the polyhydramnios it is seen. So this is stage 2. In stage 3, what will happen? Absent or reversal of umbilical artery Doppler along with oligo-poly bladder differentiation, there is Doppler changes also. Okay, so there is Doppler changes also. One or in stage 4, what will happen? One or both the twins presents with fetal hydrops. There is complication that has already started with that of the baby. Okay, so that is why it is stage 4. So now to remember, to just imagine this photo for your image sake or recollection. So it is in the first one, we just have the poly oligo, that's all. Here bladder plus one is negative. Here there is Doppler changes that we can see. Okay, and last there is fetal complications that we can see. Okay, this is how you will recollect in your exams. So which stage of the TTDS it is. Now coming to trap, it is a reversal of arterial perfusion. So here it is only one baby which is pushing the blood to the other. There is no cardiac twin it is. Okay, acephalic or acardiac twin. So this baby has an extra pressure. So we can ligate with the lasers. Less than 26 weeks we use laser for ligation of this. Okay, for blocking this vessel, and then there will be good prognosis of this. Okay, so before concluding, some other images also I wanted to show. What is the image shown in this? Peri-umbilical sparing is there. Okay, the itching or dermatological lesions in pregnancy. Two important images that I wanted to show. Maybe they'll ask you in your exam. So whenever there is a itching or rashes seen, sparing the umbilicus. Okay, peri-umbilical sparing as shown in this image. you can see this peri-umbilical sparing is there. Then it is a polymorphic eruptions of pregnancy. When there is bullous pemphigoid lesions, these are pemphigoid gestationalis. Okay, so this is for your information, maybe not, but still extra information from my side. Okay, next coming to the NST. With NST, we'll conclude this class. So NST, it is baseline heart rate that we see, baseline variability, accelerations and decelerations. Okay, these are the basic things we see. So baseline is where there is no acceleration and deceleration. You will take this. In the baseline, what is the heart rate? Normally it is 110 to 160 beats per minute. Then is your variability. Wherever you saw your what do you say, baseline heart rate, there only you can check also. So the variability. There only you can check the variability also. So this variability becomes 5 to 25 is the normal variability. Then comes the acceleration. By definition, what is acceleration? Increase, abrupt increase in the heart rate by more than 15 beats for more than 15 seconds. So as you can see in this, okay, this one more than 15 seconds and more than 15 beats. Okay, this much you should remember, more than 15 seconds and more than 15 beats per minute. Okay, then it is acceleration. I will show you what are decelerations soon. So this is a normal NST and CTG. How do you differentiate? Whenever there is no uterine contraction, then it is non-stress test. Baby is not under any stress. If there are uterine contraction, then it makes it as a CTG. That is cardiotocography. Cardio is the fetal heart rate. Toco is the uterine tone and its graph. Okay, this is how you will know. Okay, whether it is an NST or a CTG. Now coming to this graph. What is this graph that is shown here? So here you can see this is a CTG firstly, correct? No. So this is a CTG. In this CTG, because there is contraction. With every contraction, there is a deceleration. With the peak of the contraction, there is a nadir of the deceleration. With the onset of the contraction, the onset of deceleration. With the waving off of the contraction, waving off of the deceleration. This is called as early deceleration. And early decelerations are normal. Okay, there is no problem. Early decelerations are normal. This is physiological, especially seen in second stage of labor. Okay, this much knowledge you should have, because these are any clinical scenario they will give you in labor second stage. This is the CTG image of the patient. There is continuous decelerations that as shown in the photo. So you can see this is early deceleration. Then you'll tell, yes, it is normal, don't worry, we'll do the normal progression of labor. How do you want to deliver her? Immediate cesarean, take her for wait for normal progression, augment the labor, all these things. Since it is normal, you can wait for the normal progression, nothing to hurry. Then coming to the late deceleration. So late decelerations are like this. After the contraction is gone, the deceleration will start. Okay, so this contraction is waved off here. Then the deceleration will start, and after that it will continue. It is after the contraction, lately it is starting. It is not with the contraction. So here contraction is gone, then the deceleration is started. Okay, this is called as late deceleration. This is more commonly seen in meconium stained liquor, fetal distress, placental insufficiency. In these cases, we see a late deceleration. If in history they have described you like a meconium stained liquor is there and the present graph is like this, then here it is a late deceleration. Based on the stage of labor, you will decide. If they have given you already second stage, you will put forceps vacuum or something and deliver. If they have given you in early stages of labor, you will do cesarean section for late decelerations. Okay. Then come to the variable deceleration. There is no relation with that of the contraction. It is just having the deceleration without any relation to that of the contraction. This is seen in cord prolapse. Okay, so here we see this in cord prolapse. So now coming to prolonged deceleration. Usually decelerations will not last more than 2 minutes. If the deceleration is lasting more than 2 minutes, okay, these two lines, this is 1 minute, 2 minutes and lasting 3 and almost 4 minutes. Okay, whenever the deceleration lasts more than 2 minutes, then it is said as prolonged deceleration. If it is lasting more than 10 minutes, then it is called as change in baseline. The baseline heart rate only has come down. The baby is severely compromised. Okay, so this is what you should understand. The basic decelerations you should know is early deceleration, which is normal, late deceleration, which is seen in pathological condition, variable deceleration seen in cord prolapse, and the prolonged deceleration, fetus is severely compromised. If it is more than 10 minutes, then that is called as change in baseline. Okay. So now you will tell me what is this. I think I've already said off in the heading. So this is a reactive NST. Because why is it NST? Because there is no uterine contractions. Then there is no, the baseline is around 130, 140. The variability is around 5 beats. And there are 1, 2, 3, 4, 5, so many accelerations. And there are no decelerations. So this becomes a normal NST, a reactive NST. Last question from your last year NEET PG. Based on the NST they had given, this image is there. Okay. Okay, this is the last slide, so I'm not able to do it in a slide share or the big screen. Please cooperate and you can tell me what is this image that is shown. I mean, what is this question? A NEET PG 2025 question. Nitish, I didn't get you. You were asking early deceleration means we wait. Yes, early deceleration, normal progression. You don't do any interventions. If it is good progression, you just wait and watch. It will deliver, no problem. Okay. Early deceleration are more commonly seen in second stage of labor. Okay. So now this question, a NEET PG 2025 question, a multi-gravida woman with history of previous cesarean section is in active labor during her labor. Okay, she is a case of previous cesarean section. Okay, case of previous cesarean section, and during her labor, fetal bradycardia is noted. A mother is having tachycardia and she complains of persistent suprapubic pain. Okay, suprapubic pain continues even between contractions. Fetal head is at -1 station. Cervix is 8 centimeters dilated. What is the most appropriate step in this management? Okay, tell me the answer. Perform emergency cesarean section, proceed with instrumental delivery, perform artificial rupture of membranes, observe and monitor. Yes, Shruti has given me the first answer, correct answer. I'll just wait for some more of you to answer. Yes, Nitish also gave me the correct answer. Yes, everybody gave the correct answer. So what are you thinking? What is your diagnosis? Now they had asked you what is your management. Next time they'll ask you what is your diagnosis. What is your diagnosis? Now you'll answer me what is your diagnosis. Yeah, tell me what is your diagnosis. Not very difficult. Was emergency cesarean section because of only fetal bradycardia you answered, or anything else also did you suspect? Yes, Amruta Varshini, I understand all of you have given correct answer. Now, what is the answer for your diagnosis? No, why are you giving universal? Why did you say C? Perform artificial rupture of membranes. Not required. That's why you should know what is your diagnosis. Okay, fetal distress was not the indication for cesarean section. Here, what was the indication? She is a case of previous LSCS. I circled it also. Then, previous LSCS having continuous pain even between the contraction. There is tachycardia, fetal bradycardia. That means it is a signs of uterine rupture. Okay, uterine rupture is happening soon. So that is why you have to do immediate cesarean section in this case. Okay, not placental abruption. Yes, LB DT5GS, you gave me the correct answer. It is uterine rupture. So it is a case of previous LSCS with fetal bradycardia. So remember, one of the most significant point for to pick up early rupture is fetal bradycardia. So that is why for a TOLAC patient, whenever we are trying trial of labor in a patient, we always check the continuous fetal ACTG. Why? Because the fetal bradycardia is the earliest sign to pick up the uterine rupture. So they've given you here so many signs of uterine rupture. She's a case of previous LSCS. One is fetal bradycardia. Two is maternal tachycardia is there. She's having continuous pain even between the contraction. Even at 8 centimeters dilatation, head is not entered the pelvis. Head is in the abdomen. -1 it is, isn't it? So many signs they've given you, signs of uterine rupture. Your management is correct, but the diagnosis was uterine rupture. Okay, it was not for only fetal bradycardia. Anyways, fetal bradycardia is also one of the sign. If it was not a previous LS is not a rupture, you could have performed artificial rupture of membranes and progressed, I mean augmented the labor also. Okay, so like somebody mentioned me rupture universal, said C is the answer. Maybe he thought it is only for fetal distress that we are doing. No, it is for uterine rupture. We are doing immediate cesarean section. Okay, we do not want it to happen. Okay, so this is all for today's class. I hope you have understood well and you'll be able to answer in your exams very well and get a good marks. So please let me know if you have any queries. Yes, Nitish, they tried VBAC. I mean, they tried TOLAC. When we try it, it's called as TOLAC, trial of labor after cesarean. Once it becomes successful, it is called as VBAC, vaginal birth after cesarean. So in this patient, it was not successful. No, so it is not VBAC. It is TOLAC. We tried it, but then because of the complication, we had to end up doing a cesarean section. The notes are not uploaded yesterday. Okay, maybe the team is working on that. Just give them another 1 or 2 days time. I'm sure they will upload it to you. I'll tell them to do it at the earliest. Okay, no problem.